Could I invite Martin Ferguson to come up, and Nick Mothershaw and Julian Ranger. Nick, let's start with you. You've got an IDP hat on for this session.
Yes.
So how do you feel about the NHS developing a digital ID in isolation? Is that okay with you? If not, why not?
Well, is it okay with me as an IDP, or is it good for the ecosystem as a whole? So ideally, what we'd like to see, and OAX would like to see, is that identities are interoperable across different use cases, different sectors, be that NHS, be that other parts of government, financial services, gaming, retail, and that's the nirvana that we collectively seek. So I understand NHS's problem, its conundrum, in terms of dealing with very, very sensitive data. So that's got to be considered, respected, and protected. But the ideal would be that can be done with an ID that is interoperable across other sectors as well.
Okay. Yeah, come back.
Yeah. So actually, I'll just take slight umbrage at the in isolation comment. So we are doing this with government. We have had to, for the purposes of getting something done in our timescales, do something which you could view in isolation, but that was all kind of part of the planning agreement. We have a problem that we have to solve. I think solving the portable identity across industries is too big a problem for us to solve by today. So maybe a few years out, that could well have been solved. And certainly the view of our SRO is, this concept of health data being a particular special thing in maybe up to 5 years from now may not be an issue. People have personal data. There'll be different types of personal data. Will they view health as a very specific thing? When consumer attitudes catch up with the kind of changes people are talking about, then it probably won't be an issue. So strategically, we are saying that we are very open to this concept, but for pragmatic purposes today, we needed to get something solved and solve it for the NHS.
Okay, fair point. Martin, what's your thinking here? You have a long background in sort of local government and the health and social care space. What do the economics of identity say there? What would you like to see from a health and care point of view as a consideration here?
Well, I think, one thing is it's encouraging that people are talking about the user, but I can't help thinking that for 20 years that's been empty rhetoric. You look outside that window, just have a look. 2,500 of our members are working out there. That is the most deprived borough in London. On various metrics, it has some of the most deprived communities in the UK. There are broken families, there are children at risk, there are people with multiple health conditions. And what have we done? What have we done that's benefited them? This is my starting point. That we've done a lot of work, but out there are people who have no sight of that work. And if I look at the local government sphere, then there are encouraging signs. So I don't want to paint a bleak picture. You can go to Leeds, see an integrated digital care record in use by over 100 organisations, small, large, independent, publicly owned, over 700 individuals logging into that system and sharing information about individuals who are at risk, health conditions, social conditions, mental health conditions, and actually doing something positive to help those people. So for me, it comes back to, what's the problem we're trying to fix, and actually keeping our eye on the ball. And at what level does it make sense to develop the practice, and out of that, the open standards? So there are health and care record exemplar projects going on right now, funded by NHS England, I think. I'm correct in saying, I get very confused on these things. But those 7, I think, exemplars, including Leeds, to develop the open standards that can then be used and adopted and adapted into the local situations, like the London Borough of Newham, outside that window.
Does anyone want to come back on that?
Well, yeah, it's, from my point of view, it's very much part of the plan. The LICAs, as they're known, are part of the plan. So the one in Leeds Helm, that's one of our early adopters, potentially, for NHS Logon. So we're working with those guys. I do agree that, again, we talk a lot about identity, trust frameworks, and all that kind of stuff. People don't really understand what we're talking about at times. The change, for me, for the Empower the Person portfolio, is about giving people control of their own health information and allowing them to make it work for them. That's the concept. And the first steps are things like the NHS app, which is also in private beta at the moment. It allows you to make your bookings, get access to your record. The thing that I've seen most actually is people downloading and viewing their own health information, something a lot of them haven't been able to do previously. So yeah, I agree with that sentiment. You've got to have an eye on the ball. We're trying to be user-centric. We're continually performing user research as we're developing NHS Logon, and that's a bit why we've trodden our own path as well.
Okay, fine. Julian, talk to me about DigiMe, and particularly talk to me about frictionless identity.
So what we're doing is allowing the individual to own their data. So this is the shift that we all own our data, whether that's health, finance, social, everything that you're doing. So within the health context, that's a very significant thing. Right? It opens up what's called patient centricity, which allows us to ensure that we have the complete record wherever we are, to make sure that we can share it, we can see it, we can use it for other apps, right? We can then share it on. So at DigiMe, we've done this in Iceland as an example. They have a centralized ID. That centralized ID is linked to their health record, made it very easy. So we created the world's first patient-facing API. That took about 4 months and about less than $100,000, right? Because they had a centralized ID. So that shows you what you can do. In the States, we've integrated Cerner, Epic, Blue Button, CDA, and all of that data comes into an individual's own library on their own DigiMe. And that's every single logon is separate, right? But it's very simple. It's separate, but it's simple. It's not as difficult as it sounds. I go to a Cerner hospital. They then give me a username and password. I put that into DigiMe. Bang, my data comes down. No one's worrying about whether it's Julian Ranger, born on a certain date in 63, etc. I went in, had the episode. They gave me my username and password. It didn't need any other verification from that. Now, in the UK, we're implementing, as part of, with the NHS, the GP records first. So we've just done EMIS. We're moving on to the others over the next few months. And there, it is a bit of a pain to get it. You have to go to the doctor, the GP surgery. You have to prove who you are, which you never had to do to actually open your GP account in the first place, which is a little odd. So that's a piece of friction that doesn't make a great deal of sense. Then they have to send off to EMIS or TPP or whoever it may be, and then you get back a username and password. You enter that, but you have to enter some other details which were never asked for in the first place. Then you can get your data. So there's a bit of friction in that, and anything that could remove that friction is important. And why is that? Because if each and every one of you owns your health records, it's been proven in a big thing in the States called Open Notes that you will be healthier on the average, right? Because you engage more. People like me, I had an error on my health record for 20 years, which meant I was treated with drugs that were far more severe than they needed to have been, right? All of those sort of things disappear if you own your health record. But we've got a lot of friction in. I'm all in favor of centralized health ID, as long as it's removing the friction and isn't going to create more as I move forwards. So will it be integrated with my GP systems? Will it be integrated with the hospitals and everything else so that I can use the same one to get all my records back in a central place? So that's what I care about.
Okay, fine. So let's talk about interoperability and the ability to share information. I'm thinking about Matt Hancock's recent pronouncements about interoperability, which has been interesting. So is proper interoperability and the ability to share information really achievable?
Well, so interoperability is huge in the NHS. Obviously, I'm looking at this from the logon identity end.
Yeah.
I can't really talk about the broader interoperability standards, but there is something about, because there are so many organisations and entities involved, the NHS has always found it difficult to integrate with itself, for want of a better term. And I do think this does present the opportunity of having a single way of identifying yourself to lots of systems could allow certain amounts of information to be transferred more easily between NHS organisations. I think this is very much the DigiMe model. It's actually, there are other personal health record providers out there that have taken this concept, allow you to download information onto your phone, for example, and then you can show it in your various care contexts. So from that point of view, that opportunity, I think, is a big one, but it is a way out yet. First of all, we need people to adopt the platform, and that's users and the providers, so the Epics, the Cerners. We've got about 80 at the moment who've expressed an interest in the NHS. That will go into hundreds without a doubt. At the moment, the rate of people wanting to onboard the services is fairly rapid. But you need that critical mass of services and people before there's any possibility of sharing information.
Okay, yeah, that's fair enough. Do you want to come in?
Yeah, I wanted to ask a question in terms of, so when I got my EMIS ID, I went into my surgery. I tried to get over the phone my surgery, and they said, well, no, you can't do this over the phone, you've got to come in. So I walked into the surgery and said, I want I didn't call it an EMIS ID, I want an ID for your online system. And I was given a form, which I filled in my name and address on, and I gave it to them back, and then they gave me an ID. There didn't actually verify who I was. As long as I turned into the surgery, then that was fine. So, so my EMIS ID is essentially unverified. You're creating ID verification with digital IDs that can be done remotely, yep. Which is great because it means I don't have to go to my surgery like I did last time to get one. But how, if you can't do that remotely, how are you going to deal with that situation of the people who will need to go in face-to-face and making sure that whoever does that follows the right procedure?
So that was almost the vouching conversation that we were having a moment ago. So a couple of things. So on that, the ID that you've gone and been given through your face-to-face interaction, you can actually use that for some things in NHS Logon. Principally, if you're accessing GP records, systems, and so on. So we're not locking existing users out. Once you step out of that space and start accessing other NHS services, there could be some extra verification work that needs to be done. So that's a problem we're wrestling with right now. It's directly linked to the liability issue because you have basically been given access to records for a specific purpose by a specific data controller. Yeah. And once you step outside that, then it's different data controllers, different systems, all the rest of it. For the people that either can't travel or can't do it online, you're back to, are they being treated under this record? And can any care worker that's treating them, so not just, we don't want to place the burden squarely with the GP practices to do this. They might be being treated elsewhere. Can we put in a process that can rigorously enough link a person to that record to allow them to be vouched for? That's one thing. The other thing is if you've tried to go through the online process, we don't really want people then to try and go to the NHS front line. So what else can we do? And we're basically exploring those concepts now. Where could we send them? Instead, could we leverage existing contact centres in local authorities? Could we leverage other third parties that could do some of that verification? We don't really want people taking up an appointment to see a GP or rocking up at A&E and saying, I need my identity verified, please.
Yeah.
So essentially, interoperability comes in two ways. So when the system is having to share data without you being the focal point, it needs to know you with a common identity, right? It needs to be able to pass that. But the other way, which is the pragmatic way that a lot of it's going to be done, and both the last health secretary and the new health secretary wants this as well, is if you own your data, then you take it with you. So by de facto, you've created that interoperability. You've brought down your data from the GP, the data from maybe a private health or a hospital or somewhere else abroad, and then you take that and you can reuse that yourself so that you're asserting your own identity through actually having brought the data down and aggregated it yourself. Now, both are needed within the system because we do both sets of things. The question is, how quickly and easily can you get the data yourself is one aspect of that. And the interesting thing is you don't need as much assurance as you do if you're sharing the data from A to B, right? If it's coming from A to you, B to you, they both know you individually, and so therefore you can walk in and show your face, and I'm the same person that saw you last week, and there's my GP record.
Yeah.
I just can't help feeling that we're missing an important component in all of this argument, and that is the citizen and politicians who make decisions about priorities, citizens who actually need to be aware and understand their rights and responsibilities, you know, their relationship with data, the data that is about them, what their responsibilities are in relation to that data. You know, we have lost our way as a society, as a community. Civics just doesn't feature in the way that we educate our children. People have no understanding of what it means to be a citizen in the 21st century, in a modern democracy, so-called. You know, care.data is an absolute case in point. You know, it was just imposed from on high, and there was a reaction against it. We need to start at a level like the Leeds Integrated Care Record and go on a journey with those kind of experiences and actually prove the case, the business case, not in just an economic sense, but in a societal sense, about the value that is generated from these approaches, and go on that journey to the panacea has to be, doesn't it? That we own our data, but there's awful lot of people out there who simply do not understand what that would involve, what responsibility would come with that, and the consent that the management of consent that would come with that. So, we have to have the citizen at the heart of what we're thinking about here.
Sounds like there's an awful lot of stuff, interesting stuff going on in Leeds, which you'll know about, and you'll know about as well. Okay. Has the NHS made the same mistake as GDS in putting too much belief in lab-based user research when users don't understand or care about digital ID?
I think the proof will be in the pudding. If people want to adopt NHS Logon, it will be successful. Early indicators are very much that people are very comfortable with it as a process. It's very quick, but also the NHS itself is absolutely crying out for it. So it's not that we're just going completely, well, this is what users want. It is user needs, not user wants. But also the NHS as a system really needs this, and that's evident in the fact that we are still very early doors, but we've got so many services that are desperate to line up. So we have many stakeholders, I would say. We're not just purely servicing the patient.
Some of which will be trust, of course, and there's a question there that says, will NHS England mandate the trust to use this ID system, or will they be allowed to opt out?
Okay, well, I know it is slightly confusing. I work for NHS Digital, so we're the implementation team. We don't own the policies. Historically, there's not a lot of mandation of adopting a service particularly, or at least there have been attempts to do that in the past that haven't gone particularly well. What we have got, though, is an agreed standard that has been published now as an NHS standard, which is the standard we wrote with Cabinet Office based on GPT 44 and 45, and that is out there. And because NHS Logon will be available to use, it's basically, here's one you can use, or you can deliver something yourself. I haven't yet met a case where they've said, yeah, we really want the hassle and the cost and the expense and the difficulty of delivering a service where there might be the opportunity for them to piggyback off the fact that there's already 14 million people registered for Patient Online, for example, that sort of thing. So I don't think we'll need to, I think is the bottom line.
Fair point. Okay. I don't want my data. Why do you keep insisting I have to own it and be in control of it?
I should answer that as someone who's making the option. It's no one is insisting, and I think that is the really important point. If there is no benefit to you and there are nothing that you want to do with it, then you shouldn't, right? You should only bring that which you want to use. But I think you'll find that when you see all the new capabilities that can be provided when you do own your data, and when it's on your device or through your own system, so the data never leaves you, and you can get full health advice, you can get financial services and all the rest of it, without anybody seeing your data, you'll see that there's an absolute advantage to having it. Without that, then there isn't much advantage to having it. But no one's forcing anyone to own it, it's just that it is. You can get a lot new services and better services if you do own your data.
Okay.
I think it's,
go on, Nick. Go ahead.
It's clear that the consumers do own their data. GDPR makes that very clear.
Well, they own it. Yeah. Whether they want to bother bringing it back and physically own it.
Managing it, yes. Whether they want to manage it.
Well, that's a really important point. We ban the word manage throughout the whole company, right? No user will manage anything. And that is about actually having the right mindset about users. If it isn't as easy as one time only authenticating my data channel, and it always comes down automatically, and I get a clear consent certificate and share it. If it isn't that easy, then no one will do it. Yeah, so the word manage should be banned. No one will manage their data. Right.
Do we have any questions from the floor? I think there's one at the back there.
So what if I'm a vulnerable person and I can't own my data at a specific point in time or over a period of my lifetime where I don't have the capacity to be responsible for my data? Who is responsible for my data? Who protects me in that scenario?
I can answer that from an Iceland perspective where we covered this. So under GDPR, unfortunately, there is no limitation of that, all right? But it is reasonable that if I don't have the capacity for whatever reason, And within the Icelandic system, a doctor can put a bar on the data going out through the API. So the doctor can say, I don't consider that that data should leave to the individual. Now, obviously, they will only do that under the processes, the rules, and the regulations that allows them to do it. But yes, occasionally with health data, for example, you have to have some of those in place.
Does that answer your question?
Access to certain services.
Yes, so the services are there. I mean, the services are provided whether or not the individual has the data themselves. It is a good question going forwards whether that would deny them access to some new services. This is something we don't know yet. We're like everybody's experimenting with what it means. But you've got every country and around the world, so say we work in the US where getting your data back is covered under Meaningful Use 3. Australia's looking this way, Singapore, India, when they finally get medical records. But we don't know what it means if you didn't have the data, because there'll be new services, and would that then stop you having access to them? But Iceland certainly took the first piece, which was to say they could stop it if they wanted to.
Okay, Martin and then Adam.
Yeah, I think absolutely having the right controls in place. For me, it's again about thinking of the use cases. So in the Buurtzorg example in the Netherlands, for example, you have this holistic approach around the individual. What's their whole care need, their health need? And the impact of taking that approach has been to totally turn the care system upside down. So they have 7,000 community nurses supported by 30 support staff. You know, compare that with what's going on out there. It revolutionises the economics of providing services in the very area that is most at risk at the moment. It's under our austere environment in local public services. The biggest budget head in is social care in local government, and it's at the most risk at the moment.
Okay, Adam?
Very quickly, I was going to say, you know, whatever digital services we bring in, the NHS still has a duty of care, full stop. So, of course, they need to protect individuals. But one of the things we are looking at as well is how we can bring the unpaid carer, the people that are assisting those people living, into this conversation, basically. So we are looking at how we can do proxy, delegated access, power of attorney, whatever you want to call it, because we appreciate that people's lives are very complicated. It can't just be all about, well, I can do this stuff, happy days. So we are looking at that at the moment.
There's a question now that talks about when will the new NHS ID go live and when is it linked to my EMIS, TPP and GP records. I know you haven't sort of said when it's going live and you may not sort of know, but is there a point to cover off there?
Yeah, well, it'll be next year. It is already linked in the private beta to EMIS, TPP coming soon. So that was what I was talking about, reuse of the existing patient online identities. So that stuff is happening, but it is complex. There's a complex integration environment in the NHS. There's lots of other subsidiary suppliers and other people that we need to take into consideration. But yeah, it's all on the roadmap. It'll be available next year.
And there's another point here that says, surely the NHS frontline staff know citizens personally are ideally placed to vouch for people they know well for years and provide a vouching token / attributes. Is that a reasonable point?
Well, so the service doesn't just work one way. I've tried to make that clear. You know, you can do an online process. If somebody is being treated and there's a way for them to opportunistically say, I know this person, I want them to start using a digital tool. There's a concept that you might be prescribed a digital tool rather than anything else. I think you should start using this. And in that case, then yes, you know, there's that opportunity for someone to link a person to their health record, and the service will support that. That is something we are looking at. But the vouching process is also difficult, and in some circumstances, as we've heard on this stage, there may not be any verification where it should be required, really, to prevent things like masquerading or people being coerced, that sort of thing. So there are still need for controls around that aspect.
Okay, fine, thank you. I think we're probably just about out of time. One last point.
I'll go on for a question. So if what you're doing is successful, you already talked about the big 14 million people with logons?
With the, that's not NHS, that's
NHS
the legacy, that's Patient Online, which is the legacy service, yeah.
Well, that's 14 million starting point. So you could very quickly become the largest identity provider in the UK. What else could you do with that data? Where else could you take it?
Well, I think the whole point is we're just dealing with logon for now, rather than the rules of data sharing, the rest of it. And, you know, it depends on that broader strategy. You know, the point I think Jess made around having a framework of standards, and then how standards sit under that, that could let us have conversations about how you can rely on what has been done. Because in some ways, you might not consider it a standard identity. There's no fraud checks. There's no financial aspect to this at all.
Okay, I think we're out of time. So thank you very much.
Thank you.
We'll end that session.